talk or lecture really is from Professor Henry Schroeder. Uh, Professor Henry Schroeder, um, it's a doyen of neurosurgery. Once again, of all areas, in terms of endoscopy, he's synonymous nowadays with endoscopy. I had the pleasure of visiting Professor Schroeder now exactly 10 years ago. I went to Greifswald and I still remember it as fresh as yesterday, and saw him do a complex endoscopic operation. Yeah, he was actually using endoscopy to do MVD that day. And then I recorded lectures with him, and I hope I can share you that one. So I think you can see it. You can see that this was 9 years and probably 8 months or 7 months, and it has total of 17,000 views. So Professor Schroeder, that's quite a large number of people that who have viewed, and I find it very useful as a reference to go back. So it's great. Professor Schroeder comes from Greifswald in Germany, and Greifswald is a very, very historical department from a neurosurgical point of view. It was the first department, it was the first place to have had a shunt with a valve. It was by Erwin Peyer in 1907, one of the most famous neurosurgeons of the 20th century. He was a celebrity in Germany as well as around the world. He has got so many Peyer's eponyms for him. And he was so smart that what he did was he took the saphenous vein, and then he used that as the conduit, and he shunted the ventricle to sagittal sinus. This was back in 1907, and the patient survived for a couple of years, and he did the second operation as well. And when the patients passed away, the valve was still, the conduit was still working. And then Dr. Professor Peyer, he's originally an Austrian. He then moved to Leipzig. So it's a very important historical place, which is even enhanced by Professor Schroeder. So Professor Schroeder is going to talk to us about a very complex area. It's the aqueductal stenting and aqueductoplasty. So without further ado, Professor Schroeder, may I please invite you to give this talk to us. We are looking forward to it.
Dear Naren, thank you so much for the invitation. It's a great pleasure to be here. And I remember very well when you came to us, and it was Murphy's Law. That was interesting. We had an ETV, and one of my residents, he did not fix the mechanical holding arm very precisely, and it slipped out. And the next day, Naren posted, "Is the use of an endoscope holder safe?"
Did I do that?
But that's what typical Murphy Law. It never happened, and it will never happen again, because now I always look whether really the teeth are inside. But you remember this, right?
Yes, absolutely. But the patient was fine. It was very...
Fortunately, it fall out and not fall in. That was a good thing. But it's a heavy arm. The pneumatic Vitaka arm is relatively heavy.
Yeah.
And when there is something that not correct, it can be really dangerous. So if you have a good guy who can hold the endoscope, of course, it's also good, because it's a voice-controlled holding device. Go left, right, in, out. That's what we use in the nose for the pituitary cases, of course, very well. But in the ventricles, especially if you have small ventricles, I always feel more comfortable when it I fix with a mechanical holding arm, because I frequently do surgery with a young resident who has no experience in it. And then you have to, of course, to be careful. Anyhow, thanks again for the invitation. Great pleasure to be here. And I really admire what you do for the neurosurgery community, and always think, how has he the time to do all this? When is he doing this? No sleeping, obviously. So I should talk about endoscopic aqueductoplasty and stenting. And oh no, I have to share first. Can you see it now?
Yes, yes.
Full screen?
Yeah, it is full screen, yeah.
And moving?
Yep, absolutely.
Perfect. So I must say I was a consultant to Karl Storz, but nowadays not so much, because they have problems with the medical device regulation. so they don't need much consultation, but they are working hard. They promised us that they will be back soon in the future with all the ventricular stuff and also for the skull-based stuff. But it's a really mess for these companies to deal with the medical device regulation of the European Union. That makes the life really hard. And it's a very, very bad situation because all innovation is stopped. They just force all power they have, and it's really expensive for them to get the CE approval. But hopefully they will do it in the near future. So history. Dandy was the first one, to my knowledge, who tried to make an aqueductoplasty, and he forced a rubber tube from the suboccipital approach into the aqueduct. He left it for 10 days, and then he removed it. But then finally he stated any attempt to restore the aqueduct finally failed. And then he developed the technique of third ventriculostomy, first frontal approach with cutting of one optic nerve. And then later on he makes a subtemporal approach. And then he said that is much more reliable than to restore the aqueduct. And then Lexell was the first one who put a stent in, but the mortality and morbidity rate of this series was very high, so it was abandoned as well. And in 1993, Oka was the first who reported an aqueductoplasty using a balloon catheter. And I must say, Michael Garb also before 1993 tried aqueductoplasty, but he did not publish it. So he was in my place. He was one of the pioneers of neuroendoscopy together with Dieter Hellwig and Axel Panetsky. And we published our first paper about endoscopic aqueductoplasty in 1990. And I was really enthusiastic about it because with endoscopic aqueductoplasty, you restore the aqueducts, the natural CSF pathways. You have no basilar artery, which is close to you. You have no arachnoid adhesion, what you have frequently or sometimes under the floor of a third ventricle. So theoretically, this was a really, really nice technique, and I enjoyed it to do it. This was a Garb scope that we used at that time. Here is a Garb scope, here is a tube. And we have also used a flexible 2.5 millimeter in diameter flexible scope to inspect the aqueduct. The aqueductoplasty per se is performed in most cases with a Fugate balloon catheter, and you have to look very accurately at the MRI. The aqueduct is not always a straight tube, but sometimes it's curved, and then it's nice. Then you also bend the tip of the Fugate catheter to avoid puncture of the tactile plate. So what are indications for endoscopic aqueductoplasty? Of course, aqueductal stenosis. And the second indication is a trapped fourth ventricle. These are the both indications. So what is important to have before you start the surgery? Of course, good imaging. Besides the standard T1, T2 images, we always have an inversion recovery turbospin echo sequence, which shows flow as a black signal. And you see here in this aqueductal stenosis, there's no flow. So you know there is something wrong. And then we use the high-resolution T2 weighted images. We have some Siemens machine. It's called KISS, constructive interference in steady state, but it can also be Drive or Fiesta, depending on the machine you have. But it's a high-resolution T2 weighted images, which shows here's a bulging of the lamina terminalis, distortion of pituitary stalk, bulging of the floor, pre-stenotic dilation of the aqueduct, so all signs of hydrocephalus, which gives you a clue that it's really an obstructive hydrocephalus. So the entry point for aqueductoplasty is far more anterior compared to the coronal borehole that we use for ETV. So we come from far anteriorly. The best is at least 4 to 5 centimeters in front of the coronary suture, but sometimes depending on the hairline, we just place it at the border in the forehead so that it's for cosmetic reasons. If you have a bald head like me, then you have to take a wrinkle to place it anatomically nicely or cosmetically nicely. And then we go directly to the aqueduct, put the catheter in and dilate a little bit. We should not dilate as much as shown here in this schematic drawing because there's a central gray around it. So that's a typical case. We look with an endoscope. You see this is a posterior commissure. This is a pre-stenotic dilation of the aqueduct, and here's the membrane. When you go very close, usually with a 30-degree endoscope, in all cases we found a pinhole which is still open, which obviously prevented the deterioration of the patient. But this is all stenotic aqueductal stenosis, and we come with a Fogarty balloon, we dilate a little bit, and you see it looks like new. It's really a very nice atraumatic technique. Sometimes it's not so easy. You see, this is a lady with a typical 3-ventricular hydrocephalus. You see the bulging of the floor, distortion of the stalk, and you see here it seems to be a stenosis, but there is some flow. But here distally, very distally, there's another stenosis. So this, of course, is very difficult to reach when you come with a rigid scope only. You cannot come to here. So that's why in this case, we use the mother-daughter principle. That means we introduce the flexible scope through the working channel of the larger scope. Here, when you go into the foramen, we always go back to see the margin of the sheath to make no damage. Here you see mammillary bodies. And then the endoscope is turned a little bit backwards. You see posterior commissure. This is a dilation of the aqueduct as shown on the MRI. And you see it's very difficult to see where do we go. That's why we take now the flexible scope. At that time, we had no tip on the chip, but the fiber scope. And here you see the first stenosis, which is really not very narrow. So we go easily in, then you have to bend the endoscope, and then you see the second stenosis here. There's again, this is a pinhole, which is still open, but this is all membranous aqueductal stenosis. And now we just push the endoscope through, ruptures the membrane, and you see here the core plexus, the fourth ventricle. When we go down to Mahjong D, which is wide open, you see here the cervical spinal canal. So this can all be done with the technique of aqueductoplasty. But here, of course, you need the flexible scope. It's very important that you go the same way out as you came in, with the same bending, to avoid damage to the aqueduct. Okay, here you see the mother-daughter principle. This is a view from the rigid scope. And afterwards, you see the good flow void through the aqueduct. And you see the distortion of the floor is reduced compared to the pre-op images. So it's a nice technique. Another indication is trapped fourth ventricle. Usually it occurs in patients who were shunted. This was an older patient, came later also with a shunt introduced. You see large enlargement of the fourth ventricle, but here's a very, very small membranous stenosis. So in this case, a retrograde aqueductoplasty was performed under navigational guidance. The endoscope is introduced into the fourth ventricle. And then we look here, this is a rhomboid fossa. And when you go up, you see here the aqueduct, posterior commissure. And this is a lucky case because it's a very, very thin membrane. Just the membrane is perforated with the closed biopsy forceps. And then a Fogarty balloon catheter is used to open this stenosis. And then you see the core plexus at the roof of the third ventricle. So this is an easy technique. And you see, this is a good flow void, reduction of the size. And I had the luck to see her for other reasons 14 years later. And you see, still open, no aqueductal reocclusion. That is, for trapped fourth ventricle, a rare occasion, but probably it was because it was just a membrane. What we do usually in trapped fourth ventricle is stenting, because there's a high rate of failure. When you look to the literature, the aqueductoplasty alone in trapped fourth ventricle is rarely successful. One example, 40-month-old male, premature newborn, post-hemorrhagic hydrocephalus, typical history in these cases. And you see large fourth ventricle, but very narrow lateral ventricle, and also the foramen of Monroe, which are more on the lateral side, but I have no image here, was very narrow. So we have to decide how can we bring the stent in. There are two techniques which I use. One is I go through the working channel, and one I go aside. So in this case, I use the Lotta. This has a diameter of 6.8 millimeters. But I can take the ventricular catheter through the working channel of the scope. And if the foramen of Monro is narrow, which is almost in all of these cases the case, I use this conical shaped trocar. This is introduced in the endoscopic sheath, and I have a camera, a 0-degree endoscope, and under direct view I can go in, and because of the conical shape I can dilate the foramen of Monro a little bit. This is the case. We look in, you see the cyclops ventricle, means there is no septum. Here's the fornices. You look to the left side, right side, you see here's the fornix, and you see the foramen is very narrow. When I go with this endoscopic sheath, I damage the fornix or the vein. So that is not a good idea. That's why I change now to the optical trocar. And then I can go in, and because of the conical shape, I dilate the foramen. This is the mammillary bodies here, posterior commissure. And you see some hemosiderine remnants in front of the aqueduct. And then here is straight. Foccati balloon is taken because the aqueduct is straight in this direction. It's perforated, and then carefully just inflate, not much, just a little bit. And then you can take the small scopes. They have a diameter of 2 millimeters. With a 1.2 millimeter optic, you go in and can confirm you are in the fourth ventricle, rhomboid fossa, Luschke was visible. And then the stent comes through the working channel of the lotoscope. It's introduced. You have seen we make side holes here to communicate all ventricles with one catheter, and then you can connect the shunt directly to this catheter. And you see here's a side hole. The problem now is you have to withdraw the endoscope without dislocating the catheter. And then to confirm it's really not dislocated, I go with a small scope again into the ventricle to make sure, the stent is still in a good place. And then this ventricular catheter is fixed to a Bohr reservoir or to a shunt system. See the post-op MRI shows collapse of the fourth ventricle. It's another case, post-hemorrhagic hydrocephalus, VP shunt, as usual. You see a huge dilated fourth ventricle. And in this case, we use the little lotter. Of course, the ventricular catheter is not fitting through the working channel. So we have to place it aside of the scope. This is another technique. You see the difference between the larger lotter and the little lotter is pretty much. So we go in. We see here the foramen of Monro. Now we have the little lotter. The little lotter fits in without the optical trocar, but I have control of the edges when I go in. Mesa intermediate is pushed backwards. And you see down here the aqueduct. This is a posterior commissure. Then I take the Bugatti catheter to open the aqueduct. I take an endoscope to inspect. You see the quality of the endoscopes is reduced. We have to replace it, but so far we cannot get it. And then I take the catheter aside, lateral to the little lotter. Then you have to bend the tip a little bit that you can go in. And then I force the catheter through the aqueduct aside of the little lotter scope. Now, because the ventricle catheter is too thick. And you see the side holes here. Bring it in. And then you have not the risk that you have a dislocation, of course. You see the catheter is here in place and connected to a shunt system and fixed with a Bohr reservoir. So these are the two techniques which I use. There's another case, also same history, severe retardation, unfortunately. As an isolated fourth ventricle, the previous institution tried to place a stent between the fourth ventricle and the subarachnoid space, but this was not working. When you look here, where is the aqueduct? Hard to define. But when you look to the coronal view, you see here is the bulging of the fourth ventricle roof. to the lateral ventricle. And you see on the side, you also see it's a good place. You make a ventriculostomy between the lateral ventricle and the fourth ventricle. Or if you want, so it is it's the elevation of the tila choroidea from the ventricles. So you make an interventriculostomy. It's not an aqueductoplasty and not an aqueductal stenting. It's an interventriculostomy directly from this cavity to the lateral ventricle here, which you should open, and there are a lot of vessels inside. But this is an alternative when you cannot reach into the third ventricle and make an aqueductoplasty. When you look on the lateral view and the coronal view, you see a direct way which you can achieve from the lateral ventricle to the dilated fourth ventricle. But the anatomy is very distorted. So navigation, of course, is very helpful that you find the way to the lateral ventricle, where you have the thinnest part of this membrane to the third ventricle. So we go in here. You see here is a thin area. But navigation, of course, is very helpful to guide the way that you get not lost, because the anatomy is very distorted in this case. But here it seems to be a good place, not too much vessels. Then with the deck forcer, we open the first layer, which is the wall of the lateral ventricle. And then you see here the tela choroidea with all of the vessels. And we look for a place where we can make a fenestration, where we have not too much vessels. Bologna catheter is taken to open it. And then we can go. This is a guillotine knife, which can be taken to cut very safely, because you have not the blades of the scissors, which otherwise go in the depths. You see what's in between the branches and the knife. So we make a wide opening. And then we can go in with the endoscope. You see here is the ventricular catheter. We did not pull on it because it was very sticky. We just leave it inside, but you see the dilation of the fourth ventricle. And then we place again through the working channel of the Lotta a catheter in dilated fourth ventricle, and then we remove the Lotta scope. And again, you have to take care that you have no dislocation, of course. And you bring this out. Here we check it again. All good. Stent is in good position. So 3 months after surgery, you see a reduction of the size. And then he came 10 years later with a control because of shunt problems. But you see the fourth ventricle is pretty good drained, very small, and the stent still in place. Okay, we have done altogether 34 aqueductoplasties. Fourth ventricle, we have a little bit more. This is an old evaluation. There were 8 cases. And in 20 cases, we had just an aqueductoplasty. In other ones, we started with ETV, and then we look to the aqueduct, and we make the aqueductoplasty. Of course, just one is sufficient. Makes no sense to take both, but it was in the initial phase where we tried to see whether aqueductoplasty will work or not. And this was an evaluation which we had initially with these cases. 76% improved, 21 were unchanged, 3 worse, and 4 of them underwent shunting. And then we make an investigation to the flow, and it shows that we could found, compared to healthy volunteer, we can restore with aqueductoplasty a normal CSF flow in the aqueduct. So it's very nice. So what we wanted to have is the natural restoration of CSF flow, and that worked very well. So we were very happy with this. In the tapped fourth ventricle, we had clinical improvement in 75, and in 7 of the cases, the ventricle became smaller, also quite okay. We had no mortality. but we had 2.3 permanent deficits and transience deficits. And we had one problem with this conjugate eye movements, because the surgeon you see here is not hitting through the aqueduct, but a little bit laterally. And this caused oculomotor problems. And we had diplopia, also because of inflation of the balloon, but this was temporary just. And we had one trochlear palsy because you see the surgeon perforated the tactile plate because this tip of the catheter was not bent. But unfortunately, just a temporary problem. And when we had one epidural hematoma, which occurred in this guy with high intracranial pressure just after the ETV, because of the reduction of the pressure in the brain. It was also not a big problem. We just evacuated and was okay. And this was, you see, all the problems occurred in the initial experience, showing the learning curve of the aqueductoplasty techniques. How to avoid complication? You have to look to the MRI to see the configuration of the aqueduct. The bending of the tip is in most cases appropriate to follow the course of the aqueduct. No laser, no monopolar, and we use rigid optics and then inspection with flexible endoscope. What we initially had then, we had a high rate of restenosis. This was after a mean follow-up of 34 months. You see 40% already. In one patient, we had acute deterioration. This was the patient. You see here, typical pinhole. We make an aqueductoplasty, looks good, but then she deteriorated, and after 10 days, she had the restenosis of the aqueduct. And you see here, enlargement. She was really in a very bad state, almost comatose. And then we performed an ETV and an aqueductoplasty. And then, surprisingly, both stayed open. You see both, aqueduct open, ETV open. And then another investigation we did a little bit later. We had seen patients with reclosure. For an example, young guy, aqueductal stenosis. We make a restoration of the aqueduct. Looks very nice. This is the stage which he came. You see massive dilation of the aqueduct. Very bad shape, clinical. Then we make an aqueductoplasty. You see very nicely, ventricles came down. 2003, very nice. So 7 years later, looks very good. But you see here, obviously, another small stenosis started here. And then 2007, you see the bulging and the dilation of the ventricles. And then we performed an ETV, and now he's doing fine with wide open ETV, although it's occluded. And then we ask about our long-term outcome, and we try to reach all the patients. And we were able to get most of them, and we published this paper in 2018. So this were the 20 patients where we performed only ETV, only aqueductoplasty without any ETV. 3 patients were lost, so we had 17 patients. 11 became symptomatic, so they underwent ETV. Another 4 patients had the restenosis, but so far no problems. And only in 2 patients, we could see a good flow void. Example, before aqueductoplasty, after aqueductoplasty, very nice. 60 months later, again, reocclusion. And this was, of course, disappointing that we have this high reocclusion rate. And even after many years, it occurs. Very, very interesting and difficult to explain why this happens. But finally, we have to admit that Dandy was right when he stated this in 1920, that any attempt to restore the lumen finally failed, almost in all cases failed. And when you compare it to other patients with aqueductal stenosis, ventriculostomy, the reocclusion rate was just 5%. Aqueductoplasty was 88%. So this is, of course, a little bit disappointing. Question is why this happens. And we make again phase contrast MR imaging and measured the flow. And we could see that you have a much higher flow in the ETV than in the aqueduct. You see the flow was much higher, and here the stroke volume ETV was 96 microliters, and aqueductoplasty was 24. Maybe this is a reason that we have a better flow, a higher flow, but I think also the opening of the third ventricle floor is larger in diameter and it's only a thin membrane. So I think when you have a tube, the risk of reocclusion is of course higher than in this small membrane of the floor. So our conclusion is, although that is a nice technique and I was really a fan of it, you have to admit that the restenosis rate after aqueductoplasty is much higher than after ETV. So for aqueductal stenosis patients, I think the treatment of choice is an ETV. Of course, when you see there is difficulties with the basilar, very tight space, of course, you can perform an aqueductoplasty. If you're in doubt that it will occlude, you could place a stent, of course, in these cases as well. But in most of my aqueductal stenosis patients, ETV is a very nice procedure, very easy to do, and with a very high success rate. And then when you have a trapped fourth ventricle, it's advisable that you make an aqueductoplasty and a stenting, because the aqueductoplasty alone, again, has a high occlusion rate. So thank you again for the invitation. Great pleasure to be here, Larry. Thanks.
Thank you so much, Professor Schroeder. That was a masterful lecture, amazing experience. And as always, you are very honest. And I just want to, first of all, ask Professor Mr. Shailendra Magdum your comments and questions to Professor Schroeder. Thanks, Mr. Magdum.
I kind of say it's a vast experience of doing those excellent cases with the equipment you have. Means this is something we aspire to have, and unfortunately, stores is not around. The equipment is not around to do what you do. And just a quick question is, when you get trapped fourth ventricles, which is going to be more and more common after getting the individuals who are premature with intraventricular hemorrhage and washouts done, and ultimately some of them need a shunt. Direct surgical tackling of the obstruction from the posterior fossa, or even using an endoscope through the posterior fossa. Have you tried that, and what success rate did you have?
No, we just usually come from above if possible, but when you see everything is very narrow, you can make a retrograde. But I've seen we have not much experience. We have, I think, overall we have now, I think, 14 or 16 trapped fourth ventricle, because in my area we have not so many children. Okay. So we have not a high number which where I can compare it. But the cases where we done were quite successful. And the good thing is that we communicate every compartment with one catheter.
Yes.
And then you have a simplification of the shunt.
Thank you. Great lecture, great learning experience.
The problem for me is always, what is an indication? And then we rely, of course, of our pediatricians, neuropediatrics, and ask them, is there a deterioration? Is it really symptomatic? Because we have some patients, we have large trapped fourth ventricle, but clinically it's not very apparent.
Yeah.
That's it for me as an adult neurosurgeon. It's difficult to judge, is it really symptomatic or not? And then we trust, of course, our neuropediatricians. I mean, they say, yes, there is some problem, and it is fitting to the image that it's really a compressed brainstem against the clivus. Of course, then it's a good indication to do it.
Thank you.
Thank you, Mr. Magdum. Professor Kenichi Nishiyama, please, thanks.
Yeah. Thank you, Henry. Your presentation was fantastic as usual. So thorough that actually I don't have any question for your presentation, but I think we've learned your technical tips about the bending the tips of the catheter, or the confirmation of the location of the catheter after the insert the end from with a small micro endoscope. You say the diameter is 2 millimeter.
Yes.
Yeah, and I wonder about that. If you know, please say do the drainage volume and velocity of CSF from the upper and the lower holes of the stent remain consistent if you connect the VP shunt to the stent. For example, in the isolated forced ventricular case.
So what, I don't get the question. What?
Sorry, if you connect the VP shunt to your aqueductal stent, in
Yes.
case of the isolated forced ventricle, do the drainage volume and the velocity of CSF from the upper and the lower holes for the stent to remain consistent?
I don't know. We did not measure in the tube. We
of course.
measured after aqueductoplasty, not with stenting. I don't know whether they can measure reliably in the stent the flow. Maybe it's possible. I don't know, but it's so narrow. I think that has a high inaccuracy rate, because when you see the pixels, how many pixels you have inside the diameter, I don't know whether it's working. No, that we did not do. We just measured after aqueductoplasty and after ventricular loss, and there was a big difference. But in the stent, I have no idea.
Yeah, of course. Actually, I myself, my indication of the aqueductoplasty or aqueductal stent is only for the isolated forced ventricle. As you shown, the ETV is better rather than aqueductoplasty.
I agree. I agree.
Yeah. Is it possible to consider using alternative materials for tube stents besides silicone catheters?
We take just normal ventricular catheters. I don't know whether it's better.
Yeah, the same as me. And I checked now in the chat box, and one question: if the VP shunt is already functioning, could lateral ventricle to forced ventricle be a simple option?
Yes. When the shunt is still working, you can leave the shunt and make just the stent, but you should fix it at the Bochum reservoir. Initially, when Michael Gab was my chairman, we used 4 to 5 centimeter stents, and we had some patients. You see the stent looks very nice in the aqueduct. Then after, let's say, 1 year, it was at the outflow of the fourth ventricle. 1 year later, it was cervical spine, and after 5 years, it was in the lumbar spine. So that's why we always fix it at the Bochum reservoir, and also if you have infection or something, it's easy to take it out. So always we take a long stent now.
I see. I sometimes use the same technique from parental approach. It's easy.
Yeah.
So thank you, and congratulations for your excellent talk.
Thank you.
Thank you. Thank you, Prof. Nishiyama. Dr. Georgio Palandri, you have got questions for Professor Schroeder?
Yeah, thank you very much, Professor Schroeder. I think this was really impressive videos and impressive lecture. So thank you very much. I would like to ask you, based on your huge experience, in a case of aqueductal stenosis, so would you consider first ETV rather than aqueductoplasty, or vice versa?
No. As I said, first, always ETV, because you have seen the success rate in the long term is much better. But there might be a case where you open up the floor of the third ventricle, you see a lot of membranes, or you see it's very narrow, there's no space. Although I must admit, even in the posterior fossa tumors, you always find some space to make an ETV, in my opinion. So it is very theoretically. But if there would be a case where the ETV looks not good or it seems to be dangerous, of course, then you can try an aqueductoplasty. But in most cases, it's so nice, it's a third ventricle loss to me, and you have such a good success rate that it's a procedure of choice.
And a second question, based always on your experience in a teaching hospital, what would you suggest to young surgeons as the learning curve of this kind of surgeries? What's the key point of these surgeries, and what would you suggest in steps to do for them?
First, learn anatomy. This is the most important, of course, because you see normal anatomy is easy to recognize, but sometimes in cases it's very distorted. So anatomy they should learn, and then of course endoscopic techniques. So I would advise them that they go for endoscopic courses to get some experience in the handling of the endoscope, and some training models are available for ETV. And then of course they should go to somebody who can do the technique, has a lot of experience to learn clinical cases, join them, assist them. And then, of course, when this is done, they should start under supervision to perform an ETV. The ETV per se is easy. It's technically not a big deal, but a lot of mistakes can happen and disastrous complications may occur. And I know in Germany, at the beginning, when we started here with ETVs, there were a lot of really fatal complications because of basilar artery injury, but nobody dared to publish it. We had one case where the surgeon went with the balloon behind the basilar, and then he inflated and then he ruptured a small perforator from the basilar, and it started to bleed massively, and he irrigated, it stopped, patient went to ICU, and then he rebled and died. But most of the cases were not published. But I know from lawsuits and from other informations that there were several of these cases. So with an ETV, although it's simple, when you do not take in account what can happen and be careful, then it can be a disaster. That is the problem with this technique. So as you should learn when, how to do it, where to do it, and what is the right option to do it.
Thank you very much.
Thank you very much, Dr. Palandri. On the follow-up, for endoscopists, at least from my point of view, doing an aqueductoplasty or aqueductal stenting is the height of neuroendoscopy, at least in my books, and I have seen young neurosurgeons trying to do this as soon as they can to enthusiastic ones. And what's the learning curve for aqueductoplasty and aqueductal stenting? I would like to know your thoughts, because I once spoke to Professor Andrew Groton Hughes, and as you know, he's like you, a endoscopist in heart, and he said, Naren, do 200 ETVs before you go to do third ventricular colloid cyst. And I think it's important to look after the patient. So I just wanted to have your thoughts on the learning curve for aqueductoplasty. Thanks.
I think it's difficult to say. When you say you need 100 ETVs before one aqueductoplasty, then I could not start that at that time. But I think you generally need to have skills how to operate. That is very important. And with aqueductoplasty, the problem is it's midbrain. And you have shown one case. There was an experienced endoscopist who did it, but he failed because he went paramedian, not through the aqueduct. So you have to be very careful. And sometimes the aqueduct stenosis is short, then it's easy, sometimes very long. And then you have to consider, is it really a good idea to make it? I think to see the indications, the most important thing is to see an indication, to see, yes, this case is suitable to do it, or not to jump on anything and say, I can do it. You must be very careful. It's very, very important. So I was an expert witness for one case where there was made an ETV and aqueductoplasty. But when you look to the MRI and the sagittal plane, you see there is almost no foramen of Monroe. So how can you go with a thick endoscope? And it was one of the thickest one. It was a CAMAT endoscope. It was very big. How can you go to both places? They went in, and then they ruptured the complete the fornix away, and then they punctured through the midbrain. That is a problem for an indication. You have to look at the MRI and see this is not a good case for this. Please take just a shunt. The shunt is not a shame. And that is the most important, that you really see what is the indication for it. Look at the MRI very precisely. I always teach my residents, please look at the MRI. Sometimes they say, yeah, we make an ETV. I say, no, it's not an ETV case. It's a biventricular hydrocephalus because of foramen Monroe stenosis on both sides. And that is what they should learn. And then, of course, the handling. But it's difficult to say we need, let's say, 40 cases ETV and then one aqueductoplasty. Maybe that is a good ratio, but it's a guess.
Thank you. And in terms of the endoscope, you mentioned you use the rigid endoscope and then to use the flexible at the end. Would flexible be a better choice for these, or rigid is better choice?
I think if you have a good flexible endoscope, good optical quality, of course, this can be done, and then you don't need a rigid one. But when you make just an aqueductoplasty and you have a straight path, I still prefer the rigid one because it's so easy to guide. And it's also nice, you can fix it in a holding arm, then you have both hands for the aqueductoplasty and you can inflate the balloon by yourself. You have an assistant, he can hold it. I think when you have a lot of experience, you can also do with the flexible, especially the chip on the tip, which unfortunately is not available in Europe. Then you can do it very easily, have a good optical quality. And Kenichi will confirm this because he has a lot of experience with this. There's no need for a rigid one. When you place a stand, of course, you have to place it aside of the scope, but it can be done the same like with the rigid one.
That depending on the anatomy. When you doing the aqueductoplasty, before that we examine the MRI and check the route to the. If you can use the straight route, I think that your rigid endoscope is the best option. But sometimes it's not straight, so I use the flexible scope.
Yeah, and Sunny Lam is also using the flexible now for all cases, I think.
Mm-hmm.
Yeah, thanks.
See, in Europe, we are not in a good shape because of our lovely European Union regulations. Very strange, huh? We could make gas sterilization. Why should we not use it? It's really, I don't understand it. It makes life difficult for us. It's a pity.
It is a shame. Professor Schroeder, you have got a couple of questions on the box. One from Dr. Shushil Patka. Your comment about Lapras stent. Have you come across this Lapras stent?
Lapra?
Lapra, yes. Lapras, L-A-P-R-A-S.
Like cell stent I mentioned. What is Lapra stent?
I think I will ask Dr. Patka to. Dr. Patka, do you want to come on the mic or want to add some more to the chat box?
I'm on the mic now. Professor, Lapra stent was something that was used a couple of years ago, which had a kind of a flower at the end, so it would remain in place. It was passed from the posterior fossa. Basically, it was not just a simple tube, but it had a kind of, like a Foley's catheter, flower at the end. So once it was passed inside, that flower was helped to maintain it in position, and there was lesser incidence of migration, they claimed.
Ah, okay. I have seen one that was it was a little bit thicker from the beginning. So there was a small ventricular catheter and then becomes larger, and this was put autograde from above to down to avoid. Yeah, but we have never used it, so I have no experience with this. We just take in a regular ventricular catheter and then we fix it to a borehole reservoir to prevent this migration.
Okay, thank you.
Thank you. And there's a question from Ju. What's your normal threshold value for CSF stroke volume across the aqueduct?
That is very variable. We measured a lot of patients, and it is interesting. It's extremely variable. You cannot see this is a normal value and this is a pathological value, because some patients with completely normal ventricle size have a very, very low flow where you would say, oops, this is an aqueduct stenosis, we should do something. In other patients, it's opposite. They have a flow which is larger, but still they are symptomatic. So the range, the physiological range seems to be very wide. That's why it's difficult to say. So we were not able to find and to say this is a normal flow that is pathologic. We just could compare the cohort of normal patients with the cohort of the aqueductoplasty patients, and we found that we have similar values. So we could restore the flow in the aqueduct. If you have no flow, of course, then it's a pathological value, but otherwise it's difficult.
That's great. Thank you very much, Professor Schroeder. Thank you very much for the question, Dr. George Usha. I have to mention that for those attendees, that Professor Schroeder's contribution to not only neuroendoscopy but education worldwide is just unbelievable. I think he's in the same category as the late Dr. Goodrich. I mean, he's taught every country, and certainly he's a household name in Egypt and India. and he has taught. I mean, his contribution for teaching and is just amazing. It gives a lot of time, and it's every time Professor Schroeder has sent an email, it has changed immense amount in my practice. The last one was where I had a patient with once again a patient with a congenital hydrocephalus, and my neonatology colleagues wanted to put the patient to palliation, and then I sent an email as a last, and it was a whole Sunday. We went back and forth, and then on Sunday evening, I sent an email on the listserv, and I got a reply on Monday morning, or on the listserv, Dr. Schroeder posted. I immediately sent the email and his case to my neonatology colleagues, and they immediately said, sure, we are not going to have MDT for palliation, and they changed it. So the mother gave me 3 boxes of chocolates. One for you. Thank you very much.
Thank you for your kind words, Naren. My pleasure.
Thank you.